Hello. Hi, everyone. Thank you for joining the ONC Health IT Certification Program Developer Roundtable. My name is Katie Crenshaw with Audacious Inquiry, and our team will provide technical assistance for today's session. If you need any technical support, please type your issue in the Q&A box, and one of our team members will assist you. Please be aware that today's session will be recorded. Closed captioning is also available by clicking on the CC icon at the bottom of the screen. Any questions you may have during the presentation can be placed also in the Q&A box and will be addressed in writing during the presentation. Any remaining questions we'll encourage you to submit to the ONC Health IT feedback and inquiry portal, which will be linked at the end of the presentation. The slides from today's session will be made publicly available soon after the presentation today. Today's discussion will be led by Robert Anthony with ASTP's Certification Division. And before I hand it over to him, we did want to share a disclaimer for today's session. The materials contained in this presentation are based on the provisions contained in 45 CFR Parts 170 and 171. While every effort has been made to ensure the accuracy of the restatement of those provisions, this presentation is not a legal document. The official program requirements are contained in the relevant laws and regulations. Please note that other federal, state, and local laws may also apply. This communication is produced and disseminated at U.S. taxpayer expense. So to get things started, I will turn it over to Rob.
Thanks, Katie. Hello, everyone. I am Rob Anthony. I'm the director of the Certification and Testing Division here at ASTP. And as many of you know, we administer ONC's Health IT Certification Program. Of course, ASTP and ONC are synonymous. We have a pretty packed agenda today. We're going to talk about some of the more recent enforcement discretion notices that went out. We'll be talking about the HTI-4 final rule and what its highlights are for developers participating in the Health IT certification program. We will talk about the new standards versions that have been advanced through SVAP for 2025. Some updates to how the CMS EHR certification IDs are handled on our Certified Health IT product list, our chapel. And then finally, we'll have some folks from our Technical Strategy and Analysis Division who will be talking about the insights, condition, and maintenance of certification and developments in that area. If I occasionally go on mute, it is to cough because ragweed season has begun here and I am slowly being drowned in a sea of Benadryl. So thank you all for bearing with us. And thank you all for joining us today. Next slide. So we will have myself obviously talking, Jeff Smith, who is the Deputy Director here at Certification and Testing, Sean Spurlock and Papia Paul, both from our Certification and Testing Division, and Megan Gabriel from our Technical Strategy and Analysis Division doing the insights portion of things. Next slide. One thing that I do want to put on everyone's radar, all developers, is that we will shortly be releasing the final rule draft test procedures for HTI-4, the criteria that were finalized in the HTI-4 final rule. Those Jeff will talk about a little bit later, but just so you know, we will be doing releasing draft procedures on our webpage for public comment. It actually opens today. It'll close on September 24th. We welcome all of your feedback on anything that we may have inadvertently missed or any adjustments that need to be made on those test procedures before we finalize those and publish them as the official test procedures for finalizing or for certifying to the criteria in the program. Right here at the bottom of this is where the HTI-4 public comment webpage is and where you'll be able to find those test procedures. So please take a look at test procedures and let us know what is confusing. We try to go through this with developers on a regular basis whenever we have new test procedures, and we welcome everyone's input. Next slide. I want to discuss some of the enforcement discretion notices. I think some of these are a couple of months old now, and many of you are probably familiar with them, but I just want to put it on everybody's radar, what these actually cover. I won't go super in-depth into all of these, but do want to let everybody know that those enforcement discretion notices are on our website. We do have links to them on each of the following slides, but you can also find, if you go to the certification homepage, you can also find an enforcement discretion tab or link on the left-hand side of that screen, which will take you to everything that is currently active. So let's go to the next slide. We released this enforcement discretion about electronic case reporting. Again, sort of citing the executive order that emphasized deregulation and reducing compliance costs. We finalized an update in HTI 1 for F5, specifically this paragraph F5.2, where we basically made reference to the HL7 EICR standard. It's a fire ECR standard for certification, and had put a required effective date of January 1, 2026 on it. We are currently exercising enforcement discretion for that date. That means that there is not a impending required update for this for January 1, 2026. We are essentially saying that I'm gonna do a TLDR for those who can't go through all of this, but essentially this portion here that you will see in the that references standards is what we are exercising enforcement discretion on. So the functionality is still required of what is there. However, we are not requiring the use of a specific standard in order to achieve that functionality. Obviously, we know some developers have updated to this, and we know that some will continue to update to the standard that we had adopted in HTI 1, but that is no longer, or is not currently, a requirement with this enforcement discretion in place. Next slide. Similarly, and I think of interest to very many people, is the real-world testing enforcement discretion notice. Again, looking toward reducing the burden for developers who are participating in the program. We basically have indicated that we will not exercise direct review authority for any nonconformity relating to real-world testing. What this essentially means is that we are not looking for submission of certain things related to real-world testing, and what we are in doing enforcement discretion on here for real-world testing is the submission of a real-world testing plan. As many of you who know real-world testing are familiar, there is a regulatory requirement for submitting a plan that must happen by December 15th. And then there is a year worth of collection of data on the measures that you put in that plan. And then there's the submission of a real-world testing report that would happen the year following the measurement year by March 15th. So we are exercising enforcement discretion on the real-world testing plan. Many people have asked us regarding this, whether that means that no real-world testing report would need to be filed. That is not the case. A real-world testing report still does need to be filed. We have not exercised enforcement discretion on that. However, we have exercised enforcement discretion on what must be included in the real-world testing plan, and we have limited, results. We have limited the results to reporting on health IT modules certified to the G7 through G10 criteria. These are the API-related criteria. We also have similarly gotten questions from people about whether the real-world testing enforcement discretion means that there does not need to be any real-world testing done. That is not the case. What we have done is we have exercised enforcement discretion related to the plan and related to what must be reported. But the requirements for real-world testing are still in place. They are both a regulatory requirement and that is based on a statutory requirement. If you want to read more about this, please do go to the link at the bottom on this. The other question that we get in this area is what happens after calendar year 2026? And all I can tell you at this point in time is that we have exercised enforcement discretion for this calendar year, and we have exercised enforcement discretion for calendar year 2026. We have not addressed anything that would happen after that. We do anticipate that future rulemaking may address this situation. Next slide. And with that, I am going to pass this on to Jeff Smith to talk about the HTI-4 final rule and what that means for all of you.
All right, thank you, Rob. And thank all of you for joining us on this at least wet in DC Wednesday. If we could go to the next slide, we'll jump right into it. So as a little bit of background, those of you who have been longtime observers and participants in the certification program will recall way back in August of 2024, we proposed a set of policies that would have really changed a lot of the ways in which we would have added some certification program requirements, and we would have deconstructed some of our API requirements, and we also proposed a whole new set of criteria that we called modular API criteria. And as a core function of what we proposed, we did focus on prior authorization. We focused on electronic prescribing, and we focused on real-time prescription benefits. And along with a couple of pieces of our proposals for modular and foundational API capabilities, those will really form the core of what we ended up finalizing in HTI-4. So if you go to the next slide, please. So what did we finalize? We finalized a limited set of what we proposed in HTI-2. Again, the electronic prescribing, real-time prescription benefits, and electronic prior authorization requirements in various modified forms. And really what we tried to do is we tried to focus our finalized policies to be aligned with this administration's emphases on prior authorization and e-prescribing. And by implementing actually something that was mandated by Congress several years ago, which was to include real-time benefits information specifically for prescriptions within a real-time workflow. Now, we published this in August as part of the inpatient prospective payment system. I understand through lurking on LinkedIn that some thought that that was a sneaky move for us. But it was actually quite mechanical. We can't just publish rules willy-nilly, and oftentimes we have to look for regulations that are moving and regulations that have to get passed. And as demonstration really of our commitment and demonstration of our partnership with CMS, we were able to use their moving rules. They had to finalize the inpatient prospective payment system rule by a certain date, and we were able to kind of use that as a vehicle to finalize these policies, which I would call a mark of efficiency, not a mark of sneakiness, but I'll let you all decide. And really, we did try to focus on some real important policies, which is to reduce administrative burden for clinicians, to improve patients' ability to receive timely and important information regarding their benefits, and really to facilitate exchange of electronic health information between not just providers and their patients, but providers and payers, which is, I think, an emphasis of this administration, but also a long time source of consternation. So if you can go to the next slide, please. Okay. So as far as e-prescribing, we'll talk about the benefits, and then we'll talk about kind of the nuts and bolts. So, I think e-prescribing has been a certification program requirement really since the genesis of the program in some shape or form. And we have relied on NCPDP script, which is a specific standard for several years now. And we worked actually a couple of years ago through, again, our partners at CMS to adopt the NCPDP script standard version 2023-011. And it was through HTI-4 that we took that previously adopted standard and we updated the e-prescribing certification criterion, which is B3, to require developers to support that standard and to use that standard to engage in specific transactions. Now, I think it's really important to note that, yes, this is a newer version of a previously adopted standard, and that it's got, I think, several important benefits, including improved organization and extensibility. This will support more granular and logical structuring of product and drug information, and really hopefully support more advanced clinical decision support and analytics. This improved and newer standard will also support better electronic prior authorization and medication history for prescription drugs. And again, this is, I think, going to be, once this gets out into the world and is widely adopted, there will be tangible and noticeable benefits in terms of prior auth for prescription drugs. Next slide, please. Okay, so as I mentioned, these are kind of the nuts and bolts of what we did. We are updating 45 CFR 170.315B3, which is our e-prescribing certification criterion, and requiring that modules that are certified to B3 use the NCPDP script standard version 2023-011. Now, we did build in a transition period. So developers may use either the existing standard, which is 2017-071, or the 2023-011 standard for the time period up until December 31st, 2027. After that point in time, all health IT modules that are looking to get certified to B3 or looking to maintain their certification to B3 need to be using that newer version, which is the 2023-011. We also finalized requirements to support kind of previously optional electronic prior authorization transactions. And we also removed a suite of transactions that were currently identified as optional, but when we ran the numbers and looked at the data, not many developers, if any, were really certifying to those optional transactions. So those are going to remain optional in the standard. It's not like those can't be used. We're just not going to have them be part of the certification program, which I think is an important distinction. All right, next slide, please. Okay, on to real-time prescription benefits. Now, this is a functionality that some patients in some parts of the country and some providers already have the capacity to utilize. But it's not everywhere, and it's not for the majority of patients. This is something that Congress noticed a number of years ago and actually passed legislation that modified the qualified EHR definition in statute and said that all EHRs must have real-time prescription benefit capabilities. And so we were able to propose leveraging a specific standard, again, from our friends at NCPDP, and we were finalizing in HTI-4 the required use of this standard. And, again, I think the policy and hopefully the benefits will become apparent at scale over the course of the next several months as this capability is incorporated into electronic health records and are deployed across the country. And some of these, essentially what this will do is make cost and coverage information available for patients so that they can have conversations with their providers about which prescription drugs are covered by their plans and which will provide them with more or less cost savings. So if we go to the next slide, we can talk about some of the specific provisions. So we finalized a new criterion, and this is going to be right next to our e-prescribing criterion. This is going to be at B4. And again, this is something that's going to allow clinicians to help patients assess their out-of-pocket costs and coverage information at the point of care. And this is going to be something that leverages the NCPDP real-time prescription benefit standard version 13. And no doubt this will be a standard that may get enhanced in the future, and we may be able to adopt it in future rulemakings, but this is going to set a minimum baseline that all EHRs who are certified to B4 will have to follow. We did say that this is going to be included as part of the base EHR definition starting January 1st, 2028. So that does provide a number of months for developers to integrate and then help their clients deploy. And it's, essentially that's kind of the timeline for this. We did also note that any health IT module presented for certification to the electronic prescribing criterion at B3 must also be certified to the real-time prescription benefit criterion in B4. These functionalities and capabilities are very closely linked, and so we felt it made sense that if you are in a position to prescribe prescriptions electronically, you should also have the capability to have real-time prescription benefit information available, again, at the point of care. So next slide. Okay. So as far as electronic prior authorization is concerned, this is obviously a really high priority for this administration, this secretary, and even this White House. This is I think going to be a piece of a much larger strategy as it relates to electronic prior authorization. For our part of it, though, we focused our proposals on what is on the provider side, what is on the kind of the EHR side, even though we speak in terms of health IT modules, and really the benefits are really I think widely understood and well known in terms of making it to where patients can get access to care on a timeline and at a level of complexity that they should be getting that access to care. Obviously, there is a lot of complexity that currently exists within the system, and patients and their clinicians have been long frustrated with prior authorization as a process. And obviously, this is a very complex space. There are a lot of facets and a lot of equities that are both trying to deliver care at a reasonable pace, but also trying to understand whether or not the patient deserves and has a need for that care. And so this is, like I said, going to be part of a strategy that is, I would say, much wider, but also inclusive of the certification program. But let's dig into what the specifics are on this. So next slide, please. Okay, so for those of you that were commenters or observers during the HTI-2 proposed rule, you'll note that we actually had, we proposed two criteria. One was for the provider side and one was for the payer side. And so you may be somewhat confused as to how we ended up with three criteria, all of which are only focused on the provider side. And essentially what we ended up doing, based on public feedback and based on conversations and based on what we heard during the public comment period, was that the electronic prior authorization process is layered, involves potentially a lot of different systems, and should be much more modular than a single criterion. And so what we ended up doing was we ended up focusing again just on the provider side, and not finalizing anything on the payer side. And we finalized three separate criteria, but these criteria really are just kind of the single criterion that we proposed deconstructed into kind of three criteria and distinct pieces. I think it's important to note that we understand how vital all three pieces are to the entire kind of prior authorization process. But we heard from industry that it's entirely possible that not all currently certified health IT systems would be doing all three of these pieces. And so in the spirit of the program to become more modular, we decided to establish three separate but related criteria for prior authorization on the provider side. And I think quite importantly, we ended up finalizing the FHIR implementation specifications that are developed by, have been developed by, and are still in the process of being developed by HL7's Da Vinci project. So the three criteria include coverage requirements discovery, and this defines a workflow to allow healthcare providers to request information from payers about coverage requirements. We also finalized a criterion that was focused on the documentation templates and rules piece of the transactions, which provides a mechanism for clinicians and other EHR users to navigate and quickly assemble information needed to support a prior authorization request according to a payer's requirements. And last but not least, we finalized a criterion focused on prior authorization support, which enables the submission of a prior authorization bundle from a health IT system using FHIR. And this also supports follow-up tasks such as checking the status of a previously submitted request. So before we go to the next slide, I'll just say I know that there's a lot on that we've covered in those three those three bundles of certification criteria. We will be coming out with soon some fact sheets and some resource guides that really try and break this down at a more granular level, especially on the electronic prior authorization side. So be on the lookout for those resources. They should be nearing various stages of approval and clearance, and we should have those out into the world fairly soon. So let's go to the next slide, please. On the modular API front, again, those of you who remember the proposals we made around HTI2, we did propose a pretty vast suite of modular API criteria. We had I think J1 all the way through J24 with some skipped space in between. And again, in the spirit of really what HTI4 was meant to be, we really tried to focus on electronic prior authorization and elements of that interaction set that would require modular API criteria that we proposed. And so rather than finalizing the broad suite of J criteria, we really focused our energies on component pieces that are going to be necessary for electronic prior authorization. And that includes the workflow triggers for decision support interventions and subscriptions certification criteria. Now, I think it's also important to note here that in HTI2, we proposed corresponding criteria for the server and the client side. And we ended up, again, just focusing on the client side because in the parlance of the implementation guides, that's kind of on the EHR side. And so these are the modular API criteria that are identified in the Da Vinci guides. And we ended up finalizing these as modular API criteria in the program. This, I think, represents somewhat of a sea change when we proposed these modular API criteria. We said what we were doing is trying to think about the broader landscape that is enabled by FHIR and kind of FHIR-like interactions. And this is all part of a long-term strategy that we've been under, that's been ongoing for really a number of years now to try and move from an ecosystem that is driven by documents to an ecosystem that's more driven by data. And so there are a number of things, CDS hooks and subscriptions included, that represent net new capabilities that the FHIR standard natively kind of enables. And so, I think the introduction of CDS hooks and subscriptions to the ecosystem in a formalized way through prior authorization really does provide the entire ecosystem with a set of tools and capabilities that just previously weren't possible. And this is all because of the way that FHIR operates as a kind of RESTful standard. CDS hooks provides a framework for decision making that is really quick and happens within a provider's workflow. And this, for example, would be payer coverage at order sign to harken back to the prior authorization. But there are numerous examples where CDS hooks could be a useful tool and a useful capability. Of course, we're not going to regulate anything outside of the prior authorization example at this time, but it's important to note that these capabilities will be there and likely could be useful for other use cases. The same with subscriptions. This really enables a user to be proactively notified when an event or data update of interest kind of happens or occurs. So this is how the modern web operates, and this is kind of us introducing this in a very kind of confined and constrained way through the certification program, but hopefully we'll have, or at least raise the possibility of conversations around how to use CDS hooks and subscriptions in a wider capacity. Okay, next slide. All right, so try to kind of merge the worlds together here around the G's and the J's. Want to make note here that certification to the G criteria that cross-reference J criteria in regulation text demonstrates conformance to both of these criteria. We did a public webinar at the release of, or the publication of HTI-4 back in August, and we had a number of questions that were specific to whether a health IT developer that was looking to get certified to G31 also needed to get certified to J20. And I want to kind of make clear here that if you get certified to G31 or G33, you are demonstrating the capacity and the capability to be certified to the J criteria. So in essence, you don't have to go through two separate certifications. If you're certifying to G31 or G33, you will be demonstrating conformance to the requirements in the cross-reference J. So as an example, the provider prior authorization API for coverage requirements discovery requires support for J20 for CDS hooks and specifies support for the order signed CDS hooks. This means that if you certified at G31, the Health IT module also supports the J20 capability, thus does not need to separately certify to J20. Now, I think it's also important to note that if you're a developer out there and you want to just be certified only to the capability of CDS hooks, that's something you can also do. You don't have to also be certified, to look at this in the reverse. You don't also have to then be certified to the corresponding G. And that's what is, that's fundamentally, or at least conceptually, how we're thinking about making more modular the certification program. So if you're a developer that you only want to certify to J20 or any other J criterion that we've got out there, you can do so without certifying to any other cross-referencing G criterion. So I wanted to make sure we had a dedicated slide. We got a lot of questions about that on our previous public webinar. All right, next slide, please. So as far as the adoption of additional standards that we proposed, we were able to adopt a suite of additional, I would say, related, directly related implementation specifications, implementation guides that are of interest across the department. So part of our authorizing statutory authority, we are able to, and are charged with adopting standards on behalf of the secretary, which of course covers the entire department. And so as demonstration of this capability, I think one of the very first demonstrations of this capability actually was the NCPDP script standard on behalf of Part D last year or maybe 2 years ago. But I think this is a more recent and I think probably better example of how we adopt standards as a function of our authorities that then can be referenced either as recommended or as part of another department agency's set of programmatic requirements. So in addition to the 3 implementation guides that we finalized as supporting the certification criteria for electronic prior authorization, we adopted other specifications that are currently recommended by CMS for use by payers implementing the APIs established in the interoperability and patient access and the interoperability and prior authorization final rules. And those include the Karen Consumer Directed Payer Data Exchange, or the Karen IG for Blue Button, the Da Vinci Payer Data Exchange, or PDEX implementation guide, the PDEX US Drug Formulary implementation guide, and the PDEX PlanNet implementation guide. And you can see all of the versions that we have adopted in regulations there. So I think I've got a couple more slides here. So I mentioned the public webinar that was held in August, and we culled through all of the questions, and thank you for those of you who attended that and submitted those questions. It is actually quite helpful to understand where there is confusion, and obviously there's a lot of complexity in all of this. So you know, it may sound like a platitude when we say thank you for the questions, but really it does help us gain insights into where we need to be more specific and to where we need to focus our attention on educational resources. So I'll just kind of go through these quickly before moving on to the next segment of the presentation. Which prior authorization certification criteria are included as a base EHR function, if any? And I think it's important here to say that none of the electronic prior auth criteria are in the base EHR definition. Thus, adoption and use is driven by CMS requirements for providers, such as through the merit-based incentive payment system and the promoting interoperability programs. So it's important to note, you know, this marriage between promoting interoperability and certification has existed since the genesis. It's existed for 15 years now. And it's a very similar dynamic, you know, for the vast majority of our programmatic requirements. It's dependent, the timeline for development is actually dependent on the timeline for when CMS requires users to actually use the certified technology. So that same dynamic is at play with the electronic prior auth criteria. Would you please confirm the timeline for prior authorization and associated modular APIs? Because the certification program is voluntary, there is not a specific deadline specified for electronic prior authorization certification. However, many healthcare providers participating in MIPS or promoting interoperability will be required to report on an electronic prior authorization measure beginning in 2027. By naming version 2.0.1 of the IGs for CRD, DTR, and PAS, how will the 2.1 and 2.2 fixes of the IGs be incorporated into the program? I think this is, we opined about some of this in the HTI 4 final rule, and if I can find a pointer to where we opined on that in the final rule, I will go ahead and put that into the chat in a second. But I think it's really important to understand that we have mechanics within the program that exist today that allow developers to take advantage of the standards version advancement process. Which enables them to voluntarily update health IT products certified under the program to newer versions of adopted standards. This is something that we've gone through, I think now 4 or 5 SVAP cycles, and maybe Sean, you can correct me if I'm wrong on that 4 or 5 number when you talk about SVAP. But this is a mechanism that we have used in the past and will use in the future, and we think will be helpful to ensure that where there is a better, newer, faster IG that the industry has decided is the way to go, nothing in the program will prohibit developers from using that newer, faster, better IG. That's the intent anyway. Last but not least, do the new standards preempt state laws that might require different standards? There is nothing in the requirements that preempt state laws. The requirements that we have are specific to developers who voluntarily participate in the ONC Health IT certification program. So just kind of keep that in mind. All right, next slide. Here's the handy URL if you want to go to healthit.gov/HTI4. That will take you to a set of resources that we've put together. We obviously have kind of an overarching fact sheet. There was a great blog that was published by Dr. Tom Keene, and we will also be posting, in addition to you can find there a URL to the final rule. But in addition, like I said, the certification program will be publishing a set of resources over the coming weeks and probably over the coming months with, I would say, increasing degrees of granularity, beginning with electronic prescribing and real-time prescription benefits fact sheet, and then an electronic prior auth fact sheet. And no doubt, as we march towards the implementation of these requirements, we'll be coming out with more resources, in addition to the certification companion guides that you have all come to know and love. And we will have, I think most of those resources, if not all of those resources, ready to go by October 1st, which is the effective date. So for those of you who are very eager to get certified to all of these certification criteria, you have less than 3 weeks to wait before the floodgates open and you're able to certify to all of these new and wonderful functionalities. So with that, I will go ahead and hand the mic over to Sean Spurlock. Hey, Sean, you may be muted.
That I was double muted and only got off of one of them. I apologize. My name is Sean Spurlock. I'm with the ONC Health IT Certification Program. Today I will be providing a brief overview of the standard version advancement process, better known as SVAP, to include how it works and how it can be leveraged. To Jeff's previous point, we just finished up our 5th SVAP cycle since inception, which the standards for the 2025 cycle were announced on June 30th, and as of August 29th are now available for use in our certification program. Next slide. So what is SVAP and why is it important? SVAP was introduced as part of the real-world testing, condition, and maintenance of certification requirement of the 21st Century Cures Act as a means for developers to voluntarily incorporate newer, more advanced standards, versions of standards into the certification health IT modules without the need for a formal rulemaking process, which can be a very long and time-consuming endeavor. Operating on an annual cycle, SVAP provides the certification program and ASTP as a whole with a predictable and timely approach to maintain pace with industry standard development. SVAP also reinforces ASTP's commitment to interoperability, as approved standards reflect insights gained from real-world use and implementation of certified health IT. Next slide, please. So it's worth noting the SVAP flexibility is limited only to standards adopted in certification criteria that are a part of the real-world testing condition and maintenance of certification. Developers can incorporate approved SVAP standards into new and existing certification, which this helps ensure that updated standard versions are able to be effectively implemented in a timely manner. Developers who choose to leverage SVAP standards are required to include these standards in their annual real-world testing plan for the preceding testing year. The certification program SVAP page, which is the link included at the bottom of this slide, provides more information on the SVAP process as it relates to the certification program, and just general reminder that these slides will be made available with all the included links. Next slide, please. So the illustration to the left depicts a very high level of how the SVAP process works. The SVAP cycle publicly begins each year with the opening of the public comment period and concludes when the SVAP standards become effective and available for use in a certification program. Once the comment period closes, ASTP reviews and considers all comments received and decides which standards will be included in the approved SVAP standards for a given year. Once these determinations are made, ASTP announces the approved standards which become available for use in the certification program after a 60-day delay period. And as I previously mentioned, our 2025 standards were announced on the, June 30th and became available starting August 29th. Next slide, please. So what about SVAP standards from previous year's cycle? A version of an adopted standard for use during any SVAP cycle remains available in the certification program until a newer version of that standard has been approved in the subsequent SVAP cycle. Once the newer SVAP version is approved, a previously SVAP version can no longer be used for certification. Any developer who has previously leveraged an SVAP standard is not required to keep advancing to newer SVAP versions of that same standard. All certifications to the replaced SVAP standard will remain valid in the program. And if you follow that link at the bottom of the slide, you'll be able to see a full list of all of the approved standards, not just from the 2025 cycle, but also from our previous cycles. Next slide, please. So listed here are the approved standards for the 2025 SVAP cycle. Due to time constraints, I'm not able to go through each one of these. If you'd like to learn more about the specific standards, please feel free to use the provided links to each of the standards. Next slide, thank you. And then listed here are the available ASTP SVAP resources. Collectively, these resources provide an in-depth overview of SVAP, applicable dependencies and requirements, how the cycle works, who it applies to, and what standards have been approved throughout all of the cycles. That concludes the SVAP portion. I will now pass it to my colleague, Papia Paul, for the CMS EHR certification update.
Thank you, Sean. Hi, everyone. We wanted to do just a quick overview of the CMS EHR Certification ID update that went live on September 1st. Next slide, please. So I think we also highlighted this through our program communications, but as a reminder, the CMS EHR Certification ID, also referred to as a CERT or Certified EHR Technology ID, is generated through the Chapel, which again is our Certified Health IT product list. The CMS ID can represent a single product or a combination of products that together meet 100% of the base EHR definition. And so these IDs are then used for reporting to CMS programs that require it to show the use of certified health IT that meets a minimum set of certified capabilities. It is also good to note here quickly, since it does come up, that the CMS ID is different from the Chapel product number, or Chapel ID for short. So where the Chapel ID is unique to each certified product list on the Chapel, the CERT ID or CMS ID applies to the full suite of certified products that represent a solution. So previously, the CMS ID, the syntax was tied to certification program edition. So previously we had 15C for the 2015 edition Cures update. But now, since the program has moved to an additionalist framework, we needed a way for identifiers to stay current as certification criteria continue to evolve over time. So again, as of September 1st, the CMS IDs now use a year-based prefix tied to the CMS reporting years. So for calendar year 2025 reporting, IDs now begin with 2025C, which again replaces that old 15C ID that we had in place. And then going forward, the plan is each September, a new identifier will be introduced ahead of reporting. So for example, next September 2026, the 2026 C IDs will be available, and then so on each following year. Next slide, please. So what does this mean? We're aware some developers or vendors help generate the CMS ID on behalf of their customer base. So the process for generating that CMS ID on the Chapel hasn't changed. You'll continue to use the CMS ID creator the same way as before. But again, this is different from the Chapel ID. The CMS ID is what CMS requires for reporting, while the Chapel ID is just that unique identifier for a certified product. The big difference moving forward is that a new CMS ID then will be required annually, even if the underlying product or product suite hasn't changed. And then, of course, the products do still need to meet 100% of the certification criteria in that base EHR definition. Related to that, we also updated our base definition page to match, so it displays the certification criteria specific to the current year, calendar year 2025. That page now also includes some reminder language about CERT. That's defined by CMS and how that always includes the base definition criteria at a minimum, but it might also require additional certified functionality depending on CMS program requirements. The Chapel Public User Guide has been updated to help support this change. It has more information, including step-by-step instructions on generating CMS IDs with the new syntax. So both are good references if any of you or your customers have questions. So again, if you'd like to understand what requirements apply, you can reference that base EHR definition page. If you need the ID to report to CMS, that's when you can use the CMS ID Creator tool on the Chapel. All right, next slide, please. All right, thanks again for your time. I'll turn it over to my colleague, Megan Gabriel, for insights.
Thanks so much, Papia. Next slide, please. So we are going to hold an information session on September 25th at 2 p.m. Eastern Time to really update health IT developers on the insights, condition, and maintenance of certification requirements under our ONC Health IT certification program. So we hope you'll join us. The session is going to cover developer responsibilities, key considerations for the 2026 reporting period, and we're going to provide an overview of the use of FHIR and apps measure. As you're aware, under our enforcement discretion, only one measure is required to be reported on for year one. That's the use of FHIR and apps through certified health IT measure. So this will really allow developers to focus on transparency and real-world API use without incurring unnecessary sunk costs. So developers and stakeholders, we would encourage you to attend to stay informed and really prepare for these upcoming reporting requirements. So if you'd like, please register via our events page, and that link is live both on the slide and on our website. Next slide, please. So who should attend? So all certified health IT developers are required to submit a response under the insights condition of certification. So that response will either be a measure response, so if the developer is eligible, or an attestation if the developer does not meet the eligibility requirements. So for those submitting measure responses, the data must be reported at the product level and include the data sources and methodology, as well as the percentage of customers represented. If a developer is not eligible to report, they will attest that they do not meet the threshold of, as you can see on the screen, at least 50 hospital sites or 500 clinician users across their certified health IT. And they do not, or that they do not have certified technology for the measure, or that they do not have users for that certified functionality. So developers must submit these responses, so whether it's data or attestation, every year, and the first data collection period begins January 1st, 2026, and the first reporting submission will be due July 1st, 2027, so 6 months after the close of that data collection year. Thank you so much, and we look forward to seeing you at the information session later on this month. And we are updating the CCG, and we hope to do that by the end of the week. So look out for that forthcoming guidance related to customer percentages. Next slide, please. And thank you so much. And again, please submit any questions that you have to the Health IT inquiry portal.
Yeah, thank you, Megan, and thank you all for attending today, and thanks to our panelists. That brings us to the end of our presentation. ASTP will post the slides and the recording on the healthit.gov website in the very near future. I believe most of the questions have been answered via a written response within the Q&A box, but if you do have any further questions, please use the Health IT feedback and inquiry portal. The link to that is
Hey, Katie.
Yes?
Before you sign us off, sorry, I at the last moment, we did get a number of questions, and I just sort of want to reiterate for folks about things around the real world testing enforcement discretion. Just to highlight for folks, the real world testing enforcement discretion really exercises discretion on what you have to submit around real world testing. It does not change the requirement to do real world testing. We did not exercise enforcement discretion around your having to perform real world testing measurement. Partly that is because the requirement to do real world testing is a statutory, i.e. a congressional requirement. It is a law. So the regulation includes that, and we did not exercise enforcement discretion on performing it. What it does is exercise discretion on what you have to actually report. So you do not have to submit a 2026 real world testing plan, which you would have done by December 15th of this year. You would be expected to do 2026 real world testing measurements for all of the criteria that are specified in regulation, but your real world testing results report can be limited to the G7 to G10 criteria. So that will be true for your 2025 real world testing plan that you would submit by March 15th of next year. And you can anticipate something similar, a focus on API criteria for your 2026 real world testing results report, which you would submit by March 15th of 2027. We hope to have future rulemaking or enforcement discretion that will address that. But right now, I think you can plan on it being aligned with what the current enforcement discretion says. So hopefully that makes sense to folks. But again, if you do have inquiries, please submit them through the portal at inquiry.healthit.gov.
Great. Sorry, it took me a moment to get back off mute. Thanks so much, Rob. Yes, thank you all again, and thanks for providing that additional clarification for everyone. If you do have follow-up questions, please submit them via the portal, and information with the links to the slides and recording will be shared out in future listservs from the team. So have a great rest of your day. Thank you for joining us.